So next, we're very fortunate enough to call up the great Dr. Hafiz Abdul-Aziz. Hafiz is a superstar postdoctoral research fellow here at UQCCR, where he also undertook his PhD. He's of Malaysian background, and so he has these fantastic relationships with key collaborating groups for us in Malaysia. And because of that, has been able to lead some really strong multinational PK/PD studies. And the position paper published in Intensive Care Medicine earlier this year was driven by Hafiz, and he's the first author on that. So it's a real pleasure to invite him up to talk on antifungal PK/PD. And I'm just going to load his slides. Just bear with me. So welcome, Hafiz.
Thank you, Jason. Thank you, audience, for being with me today. So we've heard the two excellent speakers talk about how to optimize antimicrobial dosing, and also we have also heard about the PK/PD targets that we can use for antimicrobials or antibiotics. So, essentially, it's the same with antifungal. So there are exposures linking concentration linking to adverse events or clinical outcome, clinical efficacy, and the way that we can optimize the dosing for antifungals are essentially the same with antibiotics. We can use a loading dose, for example, or we can also use dosing software. So what I'm going to be talking today is I'm going to be presenting the data that we have reviewed and collated in the position paper. And I'm going to be focusing on those with some data, and also where TDM is frequently done for that particular antifungal. So if you compare it with antimicrobial, antifungal PK/PD and TDM is young and it's still evolving. So for the basic principles of TDM, just for recap, so TDM can be useful for a drug or for an antifungal which has significant PK variability. And we have defined exposure range or concentration ranges that link pharmacological response, linking it to clinical efficacy and toxicity. We have defined sampling time points, and we also have assay for concentration drug measurements. So I'll go to echinocandins first. So in this group, we have anidulafungin, caspofungin, megafungin, as we know. But for this particular antifungal group, we have very few studies investigating exposure and outcomes, linking exposure and outcomes. So a bit on its PK, it's highly protein bound, and exposure can be lower in some population, especially in critically ill patients. But the implication of that is still uncertain because we have really minimal data, not robust data describing the exposure and outcome. So in terms of animal models or preclinical PK/PD targets, so the effectiveness or clinical, the antifungal activity is linked to obtaining an optimal AUC/MIC value. So this is described as being between 10 to 20 against Candida species. But for clinical efficacy, we have only one study so far by endings. So it's a large data set, 493 patients. So in this study, they studied micafungin exposure. They tried to link micafungin exposure in patients with invasive candidiasis or candidemia. And they found that AUC-MIC was associated with that favorable response. And this threshold is 3,000. So they found that AUC over MIC of more than 3,000 is associated with favorable clinical response. There is, thus far, no clear data, no clear relationship with toxicity. And for this drug, as a group, I recommend that TDM is not routinely recommended for this antifungal group. Then we go to the azoles, FLUCONAZOLE. So for the PK, shows linear PK. It's moderately lipophilic. BD is around 1 liters per kg and predominantly renal eliminated. But significant inter-individual variability, PK inter-individual variability has been seen. So with the azoles, AUC-MIC is the PK/PD index, which predicts optimal antifungal activity. And this could be between, based on our review, between 12 to 45 against Candida albicans. But for the clinical efficacy, we think that the AUC over MIC ratio should be between 55 to 100. This is based on several studies from the study of PI in 2007. So they studied 77 patients hospitalized non-neutropenic patients with candidemia. So they describe an AUC of MIC of 55.2 and weight normalized of dosing over MIC of 12. So were associated with increased patient survival. And also, if we look at another study in patients with candidemia and oropharyngeal candidiasis, so they describe an AUC over MIC of 100, or if we convert it, free AUC over MIC of 79. So these two exposures were associated with clinical cure. But for toxicity, we have a number, which is steady state concentration of 75 milligram per liters, but it's still unclear because the sample size is small. So what we have for FLUCONAZOLE right now is only exposures linking to clinical efficacy. And for FLUCYTOSINE, briefly about the PK, VD ranges between 0.6 to 0.9 and predominantly renal eliminated. So significant inter-individual variability has been seen. And what's interesting about this antifungal, it's time dependent, and based on preclinical data, we identified the value being between 20 to 45% free drug at time above MIC against Candida albicans. So for clinical exposure and efficacy for this drug is poorly described, but we have a few studies linking concentration with toxicity. So for TDM, it's more on preventing toxicity versus efficacy. For example, in this study, Vermis in 2000 in candidemia patients, so they identify Cmax of more than 100 milligram per liters associated with adverse event, hepatotoxicity and hematological toxicity. And this value, a Cmax of more than 100 milligram per liters. So this value is supported by at least 3 other older studies that I have presented here. And we also have one preclinical data, old data too, describing a Cmin value of more than 25 milligram per liter, so to prevent resistance. So this value here has been suggested for clinical efficacy. So you should target that value to prevent resistance, but it's still unclear for this antifungal, the relationship between the exposure of this antifungal to clinical efficacy. So we move on to itraconazole. PK, it's lipophilic, large VD, and cleared by hepatic metabolism, highly protein bound, and variable and non-linear PK has been described. So for pharmacodynamics, AUC-MIC is the main driver of antifungal activity, and we believe that based on the current data that we have, the value being between 25 to 50 against Candida and Aspergillus. So for clinical efficacy, we identified these two values. For prophylaxis, semen between 0.25 to 0.5, and for treatment, semen of more than 1 milligram per liter. So we have a few studies supporting this target. So for example, for this study, plus Baha, in patients receiving itraconazole prophylaxis, so they reported that a semen value of less than 0.5 so was associated with patients having breakthrough infections or die from invasive fungal infections. And we also have another study, cartilage, in patients, HIV patients with oral candidiasis. So this study reported a semen value of less than 1 on day 7 was associated with therapeutic failure. We also have one study, two studies from the same group, describing average concentration of more than 70 predicting adverse events, but it's mainly at GI adverse events. So it's average concentration of more than 70. And we move on to POSACONAZOLE. PK, it's same lipophilic, large VD, and cleared by hepatic glucuronidation. Demonstrate extreme inter and intra-individual PK variability. So for pharmacodynamics, azoles, the same AUC-MIC, and we identified 16.9, for example, against Candida albicans. For clinical efficacy, we believe that based on the data, the value is more than 0.5 in prophylaxis, and for treatment, it's you need to aim concentration of semen of more than 1. So I've presented two studies here. Shields in 2011 studied transplant patients receiving POSACONAZOLE prophylaxis. So they identified a semen of less than 0.5. So those who had semen of less than 0.5 developed breakthrough infections. So this study is also supported by data which studied AML patient population. And in another study in Walsh, by Walsh in 2007, studying patients with invasive aspergillosis receiving salvage treatment. So they reported higher concentrations were associated with a higher clinical response, and they identify a semen of around 1.25 milligram per liters. So patients who have this concentration, semen concentrations, so we're likely to demonstrate higher clinical response. Toxicity is unclear thus far, but there's an arbitrary value between 3.75 to 4, which till today is, I think, has not been validated clinically. VORICONAZOLE. So for VORICONAZOLE, it's interesting. So it's lipophilic, large VD, and cleared by hepatic metabolism. Protein binding is about 58%, and demonstrates nonlinear PK and extensive inter-individual PK variability. AUC-MIC predicts VORICONAZOLE activity. The value is between 25 to 50. But this one, we believe that the value that you should target for clinical efficacy is semen of 1 to 2. So we have So for treatment of invasive fungal infections, we have reviewed a lot of studies, and the population included neutropenic patient, liver transplant patients, and mixed heterogeneous patient groups. And in some of the studies, they have reported a semen value of more than 1, and in other studies have reported semen value of more than 2. And some have also reported a semen over MIC ratio of between 2.5, predicting the clinical efficacy. So for breakthrough fungal infections, the value is between 1.5 to 2. And we also have concentration range or exposure linking to hepatotoxicity and neurotoxicity. So based on the data that we have reviewed, so we believe that the value is between 4.6 to 6. So I think the reason why TDM is routinely not used in ICU, for example, is because we don't have the data to back up the practice. We do have the data showing feasibility, usefulness, but we don't have the data which shows that if we do TDM, if we perform TDM, so patients will get superior clinical benefit compared to standard practice. But for voriconazole, we do have the data, at least. So we have this study from single center randomized control trial in South Korea by Park in 2012. So they studied 110 invasive fungal patients. So they randomized to 2 groups, one TDM group, the other one is a non-TDM group. So in the TDM group, they control the concentration to be between 1 to 5.5 milligram per liter. So they adjust the dose within 48 hours of receiving the first dose. And the outcome, so this study is powered to for the adverse outcome, adverse events endpoint. So we could see that with TDM, patients in the TDM group reported lower discontinuation rates due to adverse events and also higher clinical response. But mortality, it's more or less the same between the 2 groups at 6 weeks. So for voriconazole, we have the data to support TDM, and I think for antibiotics, we do have for aminoglycosides. So what we need is more data to support TDM for routine TDM for antimicrobials or antifungals in a special patient population. So this is the summary that I have presented just now. So for some, we have data for both. We have animal data, we have clinical data, but we don't have a threshold for toxicity. In some, we have most of it, like voriconazole. So we need data, further data or additional data to further understand the relationship between antifungal and outcomes. And this is what we recommend if someone wants to perform TDM in the ICU or in the ICUs or hospitals. So we have recommended for FLUCYTOSINE, ITRACONAZOLE, POSACONAZOLE, but we do believe that based on the data that we have, TDM is clinically beneficial for patients receiving voriconazole for now. So for conclusion, we do need more data linking exposures and clinical outcomes, specifically clinical response and adverse events. We need to have more studies performed comparing between TDM versus standard therapy. We also need more assay which is more feasible to be incorporated into daily practice. And for some, TDM is useful, especially in critically ill patients where you expect huge PK variability. But VORICONAZOLE TDM, based on our data, is clinically beneficial, and we recommend that it should be routinely be performed. With that, I think, thank you. So all the data that I have summarized and talked about just now, so you can go to this paper, and in the appendix, I think we have listed all the studies that we have reviewed and collated to come up with the recommendation. Thank you.
That's fantastic. Thanks, Hafiz. I'll just see if there's a question here for you. It's you got two. Firstly, do you think it's safe to use super bioavailable itraconazole for conditions where the evidence base is for non-formulation enhanced itraconazole?
I think this question should be for you, Jason.
So the answer is yes. Anything which helps achieve the target concentration is good. As we know, with itraconazole in the past, was very difficult to achieve the target concentrations, and certainly I'm not aware of a threshold for toxicity that's been accurately defined, but certainly, you know, in terms of delivering the drug, which is responsible for the antifungal effect, I think that using the enhanced formulation is a very good option. And from someone else, PK/PD target seems different from the clinical efficacy target. Is it fair to say that the clinical targets are more surrogate markers, or PK/PD does not always correlate to clinical outcome? It's a good one.
I think the audience meant that the PK/PD target identified from preclinical studies different from clinical studies. So yeah, for example, in critically ill patients, I think they differ, because in animal models or in vitro or preclinical studies, it's just minimum exposure which is needed to for antifungal activity. But when you're dealing with real patients with more PK variability and difference in organ function, you might need a higher exposure to get the clinical efficacy for your patient, I think. Yes, it differs. The answer.
Thank you, Hafiz. And finally, what are your thoughts? I know that we're running a bit behind time. These are cracking questions. What are your thoughts on echinocandin exposure in critically ill patients with hypoalbuminemia? Could it be that these patients may be underdosed?
Well, it depends on.
So it's a good question.
Depends, yeah.
Unfortunately, the PK/PD targets have only been defined in terms of total drug concentration, so it remains unknown. But the assumption at the moment remains that, given that data has in many cases come from critically ill patients, that unbound concentration has already been accounted for. I do agree, though, that we could be a bit more specific with more data, but in terms of what we currently have, there is a robust relationship that exists.